Hello class, let's talk about the child with altered cardiovascular and hematological status. The concepts we're going to cover are perfusion and cellular regulation, okay? You could see there the definitions, all right? We're going to talk about some things that should be reviewed for you very briefly, okay? Hopefully, anyway. As far as general concepts of perfusion, central perfusion is generated by cardiac output, if you remember. This is the amount of blood pumped in and out each minute. Central perfusion propels blood to all the organs and their tissue, and when that fails, the heart fails, the person loses central perfusion. Tissue perfusion refers to the volume of blood and oxygen that flows to the target tissues like brain and toes and things like that, specific tissues. And then the peripheral perfusion is that perfusion of blood and oxygen to the peripheral tissues. For example, this is what we assess when we're assessing patients' extremities are warm and they are appropriate color for their ethnicity and they have positive peripheral pulses, that kind of thing, okay? All right, so we need to know the normal heart function in order to recognize what is abnormal, right? And that is all review, all right? So make sure you're familiar with the normal flow of the blood through the heart and where the vessels are so you can recognize when something's not right, okay? And this is what a normal EKG will look like. We are not going to be looking at EKGs, thank goodness. If you are in the RN program, you will get this information in 251. So, this a normal rhythm, all right? A normal sinus rhythm, you can see here what that looks like, and here are the normals. So this is a heartbeat. Each one is a heartbeat, and we need to know what's normal for our children based on age. And you do have a vital sign sheet to help you figure that out and to know that, all right? When a person has sinus bradycardia, we have a slow heart rate, right? When we have sinus tachycardia, we have a fast, abnormally fast heart rate. We are going to talk about two cardiac abnormalities that deal with perfusion in this class and for these purposes. But I want you to understand that there's really two main categories, and each of these fit into that category. And if you know which cardiac abnormality fits in which category, you would pretty much know what's going on with that person's body, all right? There's a whole table on page 1083 through 1094 of your Pearson textbook that discusses the most common congenital heart defects, all right? There are a lot, but again, I'm going to break it down to you in two different kinds in a little bit, okay? So hopefully that'll help you manage that information better. You do not need to know all the cardiac abnormalities. Like I said, we are going to discuss two for our purposes. So when we are talking about altered perfusion, we're going to talk about what signs and symptoms we might see. All right? If you can see, here are our altered perfusion signs and symptoms of the right side, and there's the list of the altered signs and symptoms on the left side. Right-sided alterations in perfusion lead to signs and symptoms of for example, fluid overload, okay? So you're going to see edema, liver engorgement. So I will tell you that in an adult, you can palpate certain markers of the certain margins of the liver. You should never be able to palpate a child's liver, all right? If you can, that's abnormal. You'll see weight gain, neck vein distension. On the left side, if you are having alterations with the left side perfusion, you're going to see fluid that's getting backed up into the lungs. So you're going to see all these signs and symptoms, all right? So retractions and nasal flaring, those are pediatric specific. The rest of these are signs and symptoms of alterations in perfusion. So, for example, heart failure for anyone, okay? Not just children. Children are going to compensate to altered perfusion by becoming tachycardic. You will see cardiomegaly, which is that abnormal enlargement. You might hear a gallop, which is a third sound. You'll hear it often in CHF patients where the blood is slowing down from the left ventricle. You might hear a murmur. They might be diaphoretic, and they might be fatigued. They would show signs of failure to thrive, and it would be, in this case, organic, right? So just a quick review. We should know these. We learn these in A&P or 150 if you're in the RM program. Preload is that initial stretching of the cardiac muscle cells prior to the contraction. Afterload is that force of the heart when it contracts to eject that blood, right? Obviously, the preload is affected by the venous blood pressure and the venous rate in return, if you remember correctly. So let's talk about our congestive heart failure. The number one cause of congestive heart failure in pediatric patients is congenital heart defects. That is what this statement means. Number one cause of congestive heart failure in pediatric patients is in congenital heart defects. All right. You can see that this can sometimes be picked up by physical exam, but here are the diagnostic studies that would be performed when considering a diagnosis of congestive heart failure. You can see that chest x-ray is going to show a heart enlargement. A Holter monitor is something that the patient wears for 24 hours. Usually, it can be more. And we're going to go over this handout and talk about the Holter monitor in class. It's not pediatric specific, okay? But it definitely fits with diagnostic studies for congestive heart failure in our pediatric patients. The 2D echo or TE, that is a transesophageal echo. They go down the esophagus. They look at the heart through sound waves. If the child needs a cardiac catheterization, they can look at the pressure changes. They can look at cardiac output, stroke volume, abnormalities. We need to make sure post-catheterization that we're watching for complications. They're the same complications that would occur in adults. So we're looking for edema, infection, bleeding including hemorrhage, hematoma. They're at a higher risk for stroke. So same things as adults, okay? We need to watch for those complications. After catheter, a cardiac cath, they would need to be on a monitor. They would need frequent neurovascular checks. They would have their post-op vital signs being taken. A big difference between pediatrics and adults cardiac catheterization is For adults, it often requires them limiting their movement, laying down in a certain position, depending on if they go in a femoral artery or vein or a mammary artery or vein. So it really depends on where they're going, what the restriction is going to be. But for our pediatric patient, yes, they still need to be restricted with their movements to help prevent complications, but their parents can still hold them. So what that means for us is we need to help with their parents to help comfort them and lower their anxiety. All right. So whether that be we help transfer them into their parents' arms or whether we make room for their parents to be in the bed with them, it is not abnormal on a pediatric unit to find that the parent is in bed comforting and lowering the anxiety of their child. All right. That's completely normal, which you wouldn't see an adult patient. If you had a spouse or a parent in a bed of an adult patient, we're going to look at them like, what are you doing, right? So for our pediatric patients prior to a cardiac catheterization, they need to be NPO for about 4 to 6 hours. We don't want them to have any skin breakdown just like adults, but we're looking for diaper rash, things like that. We're still checking for pulses. We still want to monitor O2 saturation. So we want to get baseline prior to the cardiac cath so we have something to compare to, okay? We are going to watch videos here, but we did talk about the different diagnostic. The echocardiogram, are sound waves to take a picture. And we talked about cardiac cath is a catheter that goes through the vessel in the arm, groin, or neck. They use dye to visualize structures. And you can look at more assessments for more assessment tools for our cardiac patients in our Pearson book on 1097 to 1100. Okay, so that if you wanted to look up more assessment tools, you could look there. Children do have a greater risk for complications post these types of procedures. So they are at greater risk than their adult population, okay? So we already talked about the right and left sided heart failure, but here are symptoms of congestive heart failure. Tires easily, especially during feedings. That is a big symptom for infants. So if an infant can't feed appropriately and gets tired, this is something we would have to consider. You can see weight loss or gain, irritability, tachypnea, tachycardia, nasal flaring, grunting, retractions, which we've already talked about, coughs, crackles, periorbital or facial edema, jugular vein dissension. So the jugular vein dissension you're only going to be able to see in older children. Remember our babies, infants, necks. They don't really have a neck. You're not really going to see that. Low urinary output, which we're going to call olguria, if you remember correctly, clubbing, and chest pain. Okay. All right, so how are we going to manage this? Our goal is to make the heart work better. All right. So meds are going to be given to help improve cardiac output. These are the meds we often see in children being used. We should know these medications. So digoxin increases the force of contraction. It increases cardiac output by slowing the heart rate, right? So working on the heart rate. The thing we need to watch for digoxin, we need to watch for dig toxicity. So digoxin toxicity. Our complications for that are abdominal pain, anorexia, nausea, vomiting, blurred vision. And remember, if we've talked about digoxin before and we talk about that yellow haloing, well, if let's say we're talking to a 3-year-old, they might not be able to verbalize yellow. They have not learned their colors yet. That's an emerging learning concept that starts at 4, works till 5, okay? Arrhythmias, decreased bowel sounds, and constipation are all signs and symptoms of digoxin toxicity. ACE inhibitors help lower the blood pressure. The beta blockers decrease the oxygen demand for the heart, by decreasing the heart rate. Pacemakers, you may see those with congestive heart failure. Another important thing to keep in mind as far as digoxin is that, and beta blockers and these medications, we need to know when to hold the medication. We need to be able to educate the parents about that. So we need to know that if the child or infant's heart rate is this, we need to hold the medication. That is based on their age. So if you look at your vital signs and you recognize the vital sign parameters for what they should be for heart rate, if they go below the normal parameters, we're going to hold the medication, okay? So you're going to need to know those vital signs. And I've already said that, but there you go. Diuretics are used for excess fluid in the lungs. Lasix is often used specifically. If we're using Lasix, we have to be conscious and careful about hypokalemia, right? So we may need to give potassium supplements. We may need to supplement due to the depletion of potassium from the diuretic. We need to recognize signs and symptoms of hypokalemia. The mild signs would be like muscle aches and fatigue. The severe signs would be things like cardiac arrhythmias and shock, right? All right. When we are giving medications, you can see we have to monitor for effectiveness. We need to assess the apical heart rates. We need to teach parents how to monitor and take the apical heart rates. Monitor potassium levels. We usually like to keep potassium at normal or a little bit at the high level of normal with patients with cardiac issues, okay? The research shows that decreased potassium levels lead to an increased risk of death or hospitalization. So that's why they like to keep it on the high normal. We need to monitor eyes and nose, so we're monitoring for fluid status. Remember, our best indication of what fluid status is our daily weights. You can see here torsalis de points. That is a rapid, unstable ventricular tachycardia, which is in the QRS, and they appear to be twisted. And it's often seen in hypokalemia, okay? You don't need to know about this specific arrhythmia. Just understand that hypokalemia can lead to this. All right, so management of congestive heart failure. Well, we need to maintain oxygenation and cardiac function the best possible way. We need to give oxygen at the correct rate. You guys know what the correct rate is. Your answer should be the lowest concentration of oxygen to maintain their oxygen saturation at 93% or greater. Now this is based off the doctor's order, so you may see a variation, but for our purposes and for your NCLEX purposes, we're at 93% or greater. All right? Monitoring the pulse ox, keeping the child calm and quiet, so parents should be encouraged to hold and rock and comfort their child. Maintain at least a semi-Fowler's. Remember, we are not putting them in a high Fowler's because sitting them straight up will push on their diaphragm and cause them even greater trouble breathing. So we don't want to do that either, okay? Our nursing management should be promoting rest. So we're talking about uninterrupted rest times. This should remind you of OB when you talked about newborns and clustering care, right? So we cluster our care so that they can get lots of rest in between. Feeding should last no more than 20 minutes. It should be high caloric, calorie-dense formulas. They should have frequent small feedings. They should be rocked. They should have adequate burping. They may need a G-tube to help increase their calories, but if they do, we're still going to try to feed them orally to maintain that function, to prevent the oral aversions, right? And to maintain, when I say function, of all the, mouth, tongue, jaw, everything, the whole system, okay? So if they're able to, we're always going to encourage oral feedings as well, even if they're not adequate and we have to use a G-tube as well. Nursing management. So we are going to maintain these children's milestones as much as possible. Encourage growth and fine motor development. Encourage language skills, promoting developmental play. So we get to play with our patients, guys. We wanted to keep these kids on a positive developmental track as much as possible, okay? As far as nutritional support with congestive heart failure, the infant may need to be at a 45-degree angle in order to feed better. The stomach just fills better that way, okay? Absorption and digestion work better that way. We want them to be burped frequently. An increase in the caloric formula may be required. Supplements like a feeding tube, which we just talked about, and we need to prevent constipation. All right, and we talked about we might need a feeding tube, and we definitely need to prevent constipation, just like in adults, because the strain on the heart affects. So when you have to strain to go to the bathroom, it puts a strain on your heart. All right? All right. So you can see here we need to provide emotional support, keep the parents informed, help to refer them to as many services as we can, including support groups. Support groups are very important. They help people be able to talk about things that they may not talk to other people about because they might be scared of being judged. Also, if they're having a hard time with something, it is likely that another family has had that same difficulty, and they may be able to offer advice on how to help and things like that. Okay, so it is invaluable for them. As far as reducing the risk of a cerebral vascular accident, in this case, chronic hypoxia triggers an increased production of the erythropoietin by the kidneys, and so with that there's a greater risk for clotting. you can see that polycythemia right here is an excess of the red blood cells. It is also called, some people also call it hemoconcentration, and it's due to hypovolemia, and that again it stimulates the erythropoiesis and clotting clotting factors and clotting disorders, and so it's super important for us to prevent dehydration in these patients. Okay, children are at a greater risk for ACVA because of stasis, which is the same with adults, but they have much smaller diameter vessels, so they are at a greater risk. All right, so what we need to do as nurses is make sure we're ambulating our patients, maintaining adequate oxygenation levels, and watching things like the CBCs and the platelets and all those types of things. Okay, red blood cell count, those types of things. Okay, as far as community care, you can see here what we'll need to do. We talked about a lot of these. We have to teach signs and symptoms of heart failure. So look back on that slide. It's slide 14 in this podcast or in this PowerPoint, and look and see what those signs and symptoms are. We need to make sure we know those. We need to be careful not to use the term heart failure. Okay, you can see why, because it frightens families, and we say things like the heart is working hard or fluid overload, so we use different terms other than heart failure. We need to teach parents how to administer those medications like digoxin, where they need to monitor those heart rates and know when to hold the medication based on the patient's age. All right, how to assess an apical heart rate. All right, so another symptom of a cardiac defect, is pulmonary hypertension. Pulmonary hypertension obstructs blood flow from reaching the lungs to be oxygenated. This can be from other cardiac diseases, or it can be a primary condition. Pulmonary hypertension occurs due to fibrosis and thickening of the vessel walls. Okay. It is often called orphan's disease because we don't always know the cause of pulmonary hypertension if it's not due to a cardiac defect, especially in infants. Okay, so if an infant has pulmonary hypertension and we don't have any other cardiac abnormalities, that's why they might refer to this as orphan's disease. Okay, symptoms usually occur about 50% after 50% impairment to the pulmonary circulation. So you can see the symptoms there: dyspnea with exercise, chest pain, syncope. So when they get those symptoms, they already have a 50% impairment. They usually require oxygen, vasodilators, calcium channel blockers, IV prostacyclin, and inhaled nitric oxide. The prostacyclin is a vasodilator, and it inhibits platelet aggregation, and that inhaled nitric oxide is also a vasodilator. It stops those red blood cells from forming adhesions. Excuse me. A lung transplant may be an option, but our patients don't always do well, as we discussed in our respiratory lecture. They are at a increased risk for pulmonary embolism due to that hypercoagulability and that venous stasis. Okay, I do want you to know that the average lifespan after diagnosis of pulmonary hypertension is about 2.5 years. This depends on the severity, and again, everybody's different, but that is the average lifespan. This will conclude our first part of the lecture on children with alterations in cardiac and status and hematological status.